okay? It stops in the pulmonary artery right here.
Your attention, please. Visiting hours have ended for the evening and will resume at 9 a.m. tomorrow. We appreciate your understanding. Please exit the hospital at this time. Thank you for visiting Medical Health Community General Osteopathic Hospital.
So, once the catheter is in, it directly gives us the pressure of the, we're gonna call it right atrial pressure, or CVP. Then it also gives us the pressure that we can find in the right ventricle. And it gives us the pressure that it's exerted in the pulmonary artery pressure, okay? Now, that's directly. We can directly measure these pressures with the Swan cath. However though, indirectly, we can see the function of the left ventricle, which can help us identify the pressure on the left. That's why we call it left. It gives us a left and diastolic pressure, okay? Now, the way we get this measurement, the measurement of the left ventricle, is we inflate a balloon right here. The balloon will stop all the blood from moving from this side to this side. And the tip of the catheter is open to air and it has a little bubble. That bubble senses the pressure that's being exerted this way, because remember, pressure moves this way. This is how we can get the pressure on the left side, okay? But the catheter never goes to the left side. It stops in the left branch of the pulmonary artery. So, now, this is where the complicated part comes in place. You have to remember the numbers. This one is always going to be 2 to 6. Now, I want to talk to you about something very, very, very important that has to do with cardiac cycle. So let's take a little second right here and talk about the cardiac cycle. So, the cardiac cycle has, of course, diastole, ventricular systole, atrial systole, and atrial diastole. So, atrial diastole will start at 1 and finish at 4. All that is atrial diastole. Atrial systole. And atrial diastole, it's from 4 to 8.8 seconds. What you can see here is that the diastolic portion of the cardiac cycle is very long. It's longer than the systolic portion. This is why when we have a patient that has a high rate, we are concerned about the heart not getting enough oxygen. For example, let's say the patient is at 130, okay, 140. Then if it's 140, then you don't have enough diastole. So the ventricles don't fill properly, and whenever they contract next, they send less blood up into the aorta. So you have the heart right here, the aorta comes right here, and from the base of the aorta there are 2 vessels, the right ICA, the left main, and the left circumflex. They get blood during diastole. The heart perfuses itself during diastole. So if the diastole is not long enough, it will affect our cardiac, it will increase cardiac workload and increase oxygen consumption in the heart, which, once the heart starts getting hypoxic, it will increase the heart rate. Because the heart will think that by increasing the heart rate, you can move more blood and you can get more oxygen, but this becomes a vicious cycle. The heart rate goes from 140 to 150, there's less blood coming up, less blood coming into the coronaries, more oxygen demands, and the workload increases, the oxygen demand increases, and the heart rate increases the heart rate again. So see how this is called, it's a positive feedback loop in the heart, which is not good. We do not like elevated heart rates for that reason. Now, talking about atrial cycle. Atrial is very nice because this is the systole, and all this is diastole. Now, we have to remember that most of the blood that moves from the atria to the ventricle just goes down by gravity, okay? At the end of systole, we have a 0.01 second contraction. We call that atrial kick, okay? So now, as a really cool phenomenon happens at this time, the ventricle starts contracting. So the ventricle has what we call isovolumetric contraction. It's getting ready to contract, and it starts contracting to the point where it closes the tricuspid valve. But it's still not strong enough to send blood through the pulmonary vessel here. So once the tricuspid valve is closed and the right atrium is full, we're going to call that right arterial pressure. That is a true right arterial pressure. I read books that says that it's 4 to 8. CVP is 2 to 6. It's so close, we don't, what's 2 points between friends, right? So we're going to stick with CVP, but they are, if I say RAP or CVP, same concept, okay? So anyway, that's that with the cycle and the heart. So the right arterial pressure, it gives us the preload in the heart. So it's all volume. Right here is all volume. And the numbers for that, it's 2 to 6. I want to put it right here, 2 to 6. Okay? The right ventricular pressure, now you have a good contraction and good diastole. So we have to have systole over diastole. So it's going to be 15 to 30 for systolic pressures and 0 to 8 for diastolic pressures. Now, the PAP, the pulmonary pressure, it's the same systolic, 15 to 30, and now it's 8 to 15. Okay, that's a normal. Those are the values that you absolutely have to remember. Absolutely have to remember. Okay, and the left ventricular end diastolic pressure, it's 4 to 12. And a normal cardiac index. A normal cardiac index, which cardiac output is, as we saw earlier, cardiac output is a product of heart rate times stroke volume. However, though, it's not an accurate number, because you can have a patient that is 6 foot tall and a patient that is 5 foot tall, and they can have the same cardiac output, but it might not be good for one of those two. So what we use is the cardiac index, and the cardiac index uses cardiac output and calculates the BMI. And it gets a number, and that's how we know if the patient is getting a normal, good cardiac output. And a good cardiac index is 2.5 to 5. Okay? Those are the numbers that you absolutely have to remember. But this is where it gets easy. It gets easy because if the pressure moves from left to right. If the pressure increases in the system, then the left ventricle will feel that increase in pressure, it will increase. And the left atrium will increase, and the pulmonary pressure will increase, and so forth. You know what I'm saying? So you have to look for trends, and this is how I came up with this little method that I use. You have to understand where in the cycle is where in the system is the pressure increasing. If the pressure is increasing in the lungs, these two will be high, but not these two or the cardiac index. Does it make sense? So the systemic vascular resistance is here, okay? So this is where I'm going to give you a little exercise to try to drive this home. So you have a patient that comes in to the hospital. They put us in Swan's cath, and the PAOP, study dying. PAOP is 12. And the left ventricular end diastolic pressure